and community forum. We do have a number of people joining us on the panel today from DC Health so that they can assist in responding to any questions related specifically to DC Health guidance or other questions that people have. So I'll just start out with providing the data to date, and then we can move straight into the questions. So fortunately, since last week, we've only had one more person test positive for COVID-19. And as of yesterday afternoon, there were 253 people. We still just have one person who is hospitalized, 33 people who have had COVID who have died, as we are beginning to receive reports from the Office of the Chief Medical Examiner about the cause and manner of death. That number may actually go down some because there may be people who had COVID at the time of death but did not die from COVID. But at this time, of the deaths that we've had this year, 33 people had COVID. There are 137 people who have tested positive, who have not required inpatient care, and 82 people who received inpatient care and have been discharged. In terms of placements, 4 of the people were in host homes, 86 were in intermediate care facilities, 24 were in natural homes, 2 were in nursing homes, 27 were in residential habilitation placements, and 110 were in supported living placements. Amongst provider staff, to date, 327 people have tested positive, and that includes 29 people who work at more than one provider agency. And unfortunately, we have lost 8 provider staff to COVID-19. So we can now move on to the questions.
Good afternoon, everyone. I will read the questions first for DC Health, the ones that were previously submitted. In regards to the 9/15/20 guidance from DC Health about universal eye protection, are these required to be worn when providing direct support outdoors?
I don't actually see amongst the panelists any DC Health staff currently.
Okay.
So we will watch for when the DC Health staff are here and listed as panelists so that they can respond.
Okay. So let's, for other questions for you, Director Reese, anything you may know about plans to extend the public health emergency?
Yes, so as people are aware, the mayor's order for the public health emergency currently extends until October 9th. That order is authorized by legislation from the council. This week, the council passed legislation that allows the mayor to extend that public health emergency through December 31st of this year. And so we expect to hear from the mayor's office about, the date, any extension to that public health emergency in the next couple weeks.
How can the PPP usage disqualify getting the retainer payment when the retainer payment does not consider reimbursement for the DSP wage element of lost revenue and the PPP is expressly dedicated for that expense?
So just to clarify, and I want to, here I'll provide sort of some updated language for people, but just to clarify for folks, the retainer payment, first of all, the attestation that's required is required for retainer payments that are made for any services authorized since June 3rd, after June 30th. So, there are a lot of services that could have been authorized and paid through a retainer payment prior to that date. Just to be clear about what the retainer payment does cover, it does cover some wages. It does not cover DSP wages, but there are other wages that are still included in the retainer payment. I'm trying to copy and paste from Word into the chat box, but it seems not to allow me to do that. Is that correct, people? So so that means I have to type something in. So I'll do that. And over the course of this, as I'm listening to DC Health responses, I will type in what I want to say in the chat box. But just to clarify for people, what is most important to remember, the spirit of the attestation is that you are not getting reimbursed from more than one source for the same expense. And so as an accounting measure, what you need to make sure is that if you claim a retainer payment for day services, any Q related services in day or indirect services in day, are included in the retainer payment. So, as long as PPP was not used to pay those, then you're good. I'm going to update with the 6 points that need to be included in an attestation. And I thought I could just copy and paste, but it seems perhaps I'm going to have to type them in. And so it'll take me a couple minutes, but I will type that in so that people can see the clarification. Our Appendix K actually, most of the Appendix Ks in the country require in the attestation that you have not received PPP. If you look at our Appendix K, which is what you should be relying on for your attestation, it indicates before the attestation that our retainer payments do not include payment for direct support professionals, and then goes on to include the language that needs to be included in the attestation. And I think that we probably incorrectly included a statement that's from an attestation that we borrowed from another state, which, that one provision is different because we did not include the wages because we recognized that there was another way to get those wages.
Okay, so we'll have DC Health in just a moment.
There were other questions. Crystal?
Yeah, not in my queue. I don't see anything in my queue for questions.
Okay, so there was a question today that was received. Regarding the implementation for the status of the assistive technology option of $10,000 over 5 years per person, does that begin in November? And if so, are the service coordinators ready to discuss usage and implementation so that people can start using it in November? And I don't know. What I will say generally is they will be ready, yes. Winslow's not here to confirm that, but the new waiver goes into effect in November. And so we will make sure that the service coordinators are aware of the changes that exist. There's a number of changes, including the implementation of the IFS waiver. So there are a number of issues that we'll be going over with the service coordinators to make sure they understand for November implementation. And it does appear that Daryl is now a panelist, so the DC health questions could be asked.
Thank you.
Daryl, good afternoon. In regards to the September 15th guidance regarding universal eye protection, are these required to be worn when providing direct support outdoors?
Hi, thank you. And we did receive this question ahead of this call, so that was very helpful. We brought this up to our leadership. We are going to, we understand that doing this outside presents some, concerns from your providers. So we are we don't have an answer yet. We are going to, we are discussing that. Our leadership is discussing this internally. But I will say, take this opportunity to remind everyone that, protecting all of the points of entry of COVID-19, which is all of the mucous membranes, is for your DSPs or other direct service providers, is one of the important ways to help prevent the spread of COVID between staff and with those that you provide services to, especially when you're unable to socially distance from other individuals who do not live in your same household. But we will have an answer to that. We are discussing that particular question about wearing it outdoors when supporting individuals specifically. So more update to come on that.
Okay, and a number of DSPs have raised concerns that face shields are impacting communication with people supported in homes. We have not yet been able to access alternative forms of eye protection that meet the standards required due to supply chain issues. Are there any instances when a face shield would not need to be worn? And if there are no known infections in the home and our DSPs are following all of our screening, symptoms, monitoring, temperature checks, masking, and other precautions?
We understand that we do hear from a lot of healthcare personnel that it is uncomfortable or difficult to use face shields for certain procedures or certain activities. Goggles are also indirectly vented goggles that protect from splashes in the eyes are also acceptable eye protection, but I know that this question says that they are having difficulty finding maybe that as well. That would be my suggestion if the face shield is impeding with communications, right? To use goggles instead. And then the next part of that question is about, is there any instances where you do not need to wear eye protection? The instances when you don't need to wear eye protection is if you are not going to be if you're basically not going to be in direct or indirect contact with another individual's potentially infectious bodily fluids, right, or droplets. So if you and really at the core of that is that if you are serving individuals in their homes or in their facilities, you need to, as a healthcare personnel, wear eye protection, regardless of that person's asymptomaticness, regardless of whether or not they have COVID or not. That is what that PPE guidance means in terms of universal eye protection. And the reason for that is that this is one of the ways that we're trying to keep COVID out and prevent COVID from entering or spreading within the home or facility. Thank you.
And can you please clarify what is meant by patient care areas? Does this include all common living spaces? If people are maintaining 6 feet from each other, masking, and are the shields required?
When we refer to patient care areas, we refer to any area where you may come in contact with a person that you are serving. So, you know, I know that most of the places where your providers, your direct care providers work are homes, and that would include common areas since the persons that you serve do, I hope, go to the common areas and enjoy that space. And in that case, that is considered a care area. Um, um, and then I think, I'm sorry, the last question does about eye protection?
Uh,
The last portion of that.
yes, and if people are maintaining 6 feet from each other, is masking or shields required?
Masking, I think it would be very difficult to imagine that universal masking means that you're going to wear a medical or surgical face mask whenever you're entering the home, essentially. So that's going to be regardless of whether you're maintaining 6 feet. And eye protection, universal eye protection, we would say that you are going to do that if you can come in contact with direct or indirect, right? So as long as when you enter that home, you should be wearing that eye protection. And the reason why I know that that question is asking about, well, what if we can maintain 6 feet distance? If you have to, it's really hard to anticipate when you need to go and help someone urgently or get within 6 feet of them. And there is not going to be, I don't think it's feasible to imagine that people are going to put on eye protection when they're going to do that at that immediate, we find a lot that healthcare personnel or people who are helping those individuals or serving those individuals, that when that individual needs help, they will help first before putting on the appropriate PPE. So universal masking and universal eye protection really addresses that by requiring, wearing it in those instances as the guidance put forth. So.
Okay. Another question for you, Daryl, or one of your colleagues, if they're on the line. What are the requirements set by DC Health for COVID-19 testing for staff, managers, and participants?
And I'm sorry, the question is, what's the requirements for testing of staff? Is that correct?
Correct. Staff, managers, and participants.
We do not, in the ICF guidance, I know that I don't know if it's published yet, but we are clarifying the language there. But I will, the CRF and supported living document guidance explicitly write that we do not recommend routine surveillance testing for staff or or individuals being served in those settings, with the exception of if there is an outbreak or somebody is positive in that place, an individual is positive, then there would be recommendations potentially in testing those that are staff that is working there and the residents in that home if there's a positive resident in that home. ICF, I know that there was some confusion because of the testing of staff. It said in one section testing weekly, but that's also a consideration and not a requirement for just weekly, what we call surveillance testing, meaning screening testing, right? So we don't have, that is not a requirement. And I hope that answers that question. If there's any follow-up, please let me know.
Okay. Does the Appendix K cover also services that were authorized prior to COVID-19, like in-home supports? Some of these persons were added in-home supports extended during COVID-19.
I'm not really understanding that question, in that the Appendix K explicitly says that it is retroactive to the beginning of the public health emergency, which is March 11, 2020, and it goes through the end of the public health emergency, or March 10, 2021, whichever comes first. So if a service was, so it covers that period of time. If that doesn't answer the person's question, if they could type in their clarification. And I did, for people to see, type in the changes that more accurately reflect what is in our Appendix K regarding the attestation that is needed.
And this question for DC Health, how many cases does DC Health have of a DSP who was wearing a mask having contracted COVID from the person they were serving in their home?
Hi, thank you. Good question. So one, we do have the data for DS direct care providers in the home and them being positive. I don't have the number about wearing a mask, however, off the top of my head, but we can certainly go back in our data and provide a more specific answer if we have that available. What I can share, though, in some of the outbreaks that we have investigated in DDS settings and other similar type settings, is that we find that, and probably you have all found in your experience, that once somebody is positive in the home, it pretty much spreads so rapidly that multiple individuals living in the home become positive once it is introduced into the home. And so that's, I'd like to hope that that the cases being low is part of the, is one due in fact to the all of the measures that that you have put in place as providers, and all of the precautions that you have put in place is working to keep your the individuals in the home safe. But to answer that question, we will get back to you. We'll see if we can give you an actual number to that. Not sure if I don't know the number off the top of my head, but that is what I can share based on the outbreaks that we have investigated in this setting, is that it does spread rapidly once an individual is positive in the home. It spreads pretty quickly. So we're trying to prevent that.
And just so people are, I did provide the data about the settings of our reports of positive COVID-19. I think it's also interesting to look at over time, because in the month of September, fortunately to date, we've had only 6 positive results for the month. In August, there were 15. July, we saw a bump up of 25, because in June it was down to 13. And then, as people may recall, April, there were 140, and then May 50. So clearly, as Daryl is saying, people are getting a good handle on, a much better handle on this. In terms of that kind of curve by placement type, in September, all of the positive results that we've had, 3 were in natural homes and 3 were in supported living. We have not had a positive result in an ICF, fortunately. Amongst the people that live there, I'd have to go back and look at the other data about staff, but amongst the people supported, we've not had a positive result in an ICF since August. And our last report in a residential habilitation placement was in July. So, as Daryl's saying, people are doing well and getting control over this, but I also think we're also coordinating better now with DC Health and looking at the staff reports, and we hope to even, make sure we've got a better handle on this and help get those other numbers down completely. I do think a teeny bit, we don't see very big numbers in natural homes, but we, through support from DHCF, I believe starting in May or June, began getting the CRISP, which is Medicaid reporting data, so that anyone who's tested using their Medicaid card, we're getting regular reports so that we are now hearing about, we hope, all the folks who've tested positive in natural homes. So that could also be where we see a little bump up there.
And I will thank you, Director Reese, for summarizing that. And I will want to add that I know that part of that question was asking about masks. I will say that in anecdotally through the outbreak investigations that we've done in similar type settings and other facilities, is that we really encourage providers to think about how when staff would take off their mask, really emphasizing breaks, lunch, to not be around other people or staggering that, because that's one of the things that we have found if addressing the mask question and spread within in the DDS sites. Thanks.
In the day program reopening guidelines, it is stated that all participants being assisted during mealtime should wear an apron. Is it for only those that are being assisted during mealtimes, or is it required for all persons? My screen just jumped. For all persons attending the day program.
It sounds like it's explicitly just about sort of a mealtime protocol. I would refer people, which is what I'm doing now, but I would refer people to DDS's website, which does have that. It's really it's a best practice guide that's laid out. And so each provider is expected to take that best practice guide and develop their own reopening plans. So that guidance by provider could be different. But what is spelled out, and I think, we had a group of providers, DDS staff who, and some, trying to remember everyone, I don't want to forget anyone who helped, who really worked hard to pull together and include in that guidance links to CDC and DC health guidance. And so rather than me trying to answer a real specific question about it, I would just direct people back to our website where you'll find that guidance. And it really spells out, it is more a best practice guide than specific guidance, because as I said, each of our day providers then develops their own plan and submits it for review, and it's reviewed against that guidance to make sure that all areas are addressed.
Okay, more questions for DC Health. Could DC Health provide the data or information used in making the decision that universal eye protection is necessary when there is not any known infections in our homes? Is there significant evidence that there is transmission through the eyes if the appropriate types of masks are being worn? If the masks are catching any droplets, would that not be a sufficient barrier?
Hi, this is DC Health. What I can share about that guidance is, again, a couple of things. One, the mode of transmission of COVID-19 is through droplets, and the method of entry is a way to prevent it from entering a person. The other thing that I can share with you is that we did have a discussion with CDC about personal protective equipment, and personal protective equipment is really designed to protect the individual wearing it. So I think when you ask, for example, if somebody is wearing a face mask and correctly, how much is that really containing their droplets? There's some data, but not as much data on the actual amount of protection that the person who's wearing the PPE is getting. So the answer to that is yes, it does provide source control. The amount of source control is we don't have as much data on that as the amount of protection a mask provides you. And with that said, then it does provide some sort of control, but the risk is not zero. And so layering those two things allows us to say, you know, we need to protect all the methods of entry of this virus into a person. And that for healthcare personnel, that would be wearing eye protection and wearing masks. So doing both things helps provide that level of protection. I know that if I hope that helps answer that question and provide some you know, rationale as to why eye protection has been recommended by DC Health and CDC as a form of protection and source control for individuals who healthcare personnel.
Thanks, Daryl. Will people supported have COVID-19 tests and results available prior to returning to day services?
So, as I said, the best practice guide that was put out by DDS, and then there was adult day guidance that was put out by DC Health, are the two documents that each provider agency relies on for establishing their reopening plan. There is not a recommendation for sort of pre-admission testing for people that attend the program or for any routine testing for staff and Daryl, you could correct me if I'm wrong, but I was looking through the guidance just now. I don't believe there is. So there's no requirement by DC Health that occur. That does not mean that providers may not include that in their reopening plan. I have heard from some providers that in their communication with people that attended their program previously or the families of people that attended, that they were very concerned that there be some kind of testing of everyone before they start, and providers may include that in their own plan. If a provider goes sort of above the standard that's established, I think that's a decision they can make. Those, you know, and Kirk may have some comment on how our review panel would handle it if a provider was implementing a testing regimen that's not required by DC Health, but is going to be required by the provider.
Thank you, Director. We would look at that. We would just kind of do a case-by-case review along with our health and wellness team to just see the need for that, as well as just seeing the reality of the possibility for that. So it would really be in a case-by-case review.
And this is DC Health, and Director Reese, you summarized it correctly. We do not have requirements for testing from the DC Health guidance for adult day programs. And what you said is correct. Is what we tell facilities is that you can be more stringent than what the DC Health guidance puts forth, but you cannot be more relaxed than what the DC Health guidance requires.
Okay, if there are any additional questions, please type that into the chat box.
Yeah, there was also, so the question that apparently I was the only one to receive, it was part was for us and part of it was for DC Health. And just to clarify, the part of the question that I answered already regarding will service coordinators sort of be prepared for when these new waiver, when the changes to the waiver regarding assistive technology are in place, the training for all service coordinators has been scheduled, so they will be prepared for that. In addition, there was a question for DC Health about whether you have any update on when any changes to the PPE guidance might be issued.
And so the update to the ICF document to make more clarifications, specifically on the testing of staff and other clarifications, is not published yet, but it is underway. Same for the CRF guidance. And I think the question, it's a specific PPE clarification that it asked Directory. Sorry, I'm trying to find the chat, the question on the chat as well. But
oh no, that was it was an email I got right before, and I
great.
forwarded it to you, but you might not
Good.
have seen because I forwarded it at about 11:55.
It's okay. I got it. It says revisions on the PPE guidance will be issued, particularly on face shields and applicability to non-DC Health licensed homes. What I can share is that I know, you know, after this was asked last week, I know that some individuals that are in their natural homes, for example, maybe it's their a family member or someone who lives in that home is providing care. For example, we will say that currently our guidance and what we have been saying is that if somebody if they are part of the same household, they do not have to wear eye protection around each other. We you know, we consider that as they're part of the same home bubble, therefore they do not need those items when they're taking care of someone in their home. So an example would be, I'm a nurse, but if my son who I live with is sick, I'm defined as a direct service provider, for example. That does not apply if you are a household member, individuals living in the home. And that is a clarification I can provide now. To a mask and universal.
Hi, Daryl. You're breaking
That
up.
clarifies. Yeah. Oh, sorry. Yeah.
So if you repeat everything you just said, I'm so sorry. No, I think you're breaking up a little bit. I'm not sure what's happening on your end, if you can hear me. No, can you hear me, Daryl?
Right after your reference to if you were caring for your son, even as his direct care, if you lived with him, you wouldn't need it. And what you said after that broke up.
Well, until we get Daryl back on, question in terms of clarifying, if you can clarify if we are required to train DSPs bi-weekly on the COVID-19 training you provided yesterday. We received an email on this information.
Can you hear me?
Hi, this is Kirk Dobson for Quatma. Hi, Daryl. I just want to make sure if Daryl's trying to speak here.
She says she'll type in an answer in the chat, so I can.
Okay.
I can share when she types it.
Okay, so I will just address the question that just came in on training. So the requirement is that training that was been made available on the website, and it's up on the website currently. The link will be going out later today as soon as we get that. So that training is supposed to be provided to all staff within the next 2 weeks, or 2.5 weeks, I think it is. And so the requirement is that exact training, that recording needs to be presented by your director of nursing or quality directors or quality staff to all staff in the agency within the deadline that was been prescribed. And following that training, the provider agencies are required to do a refresher training every week with their DSP staff to make sure that any updates are included from DC Health or DDS, as well as to just make sure that staff are doing what is needed and do have the understanding of what is required. So the exact recording needs to be shared with all staff within the prescribed time that was in the email. And then following that training every week, there needs to be a refresher course. And providers could either use our training that's been recorded for that refresher, or providers can develop their own tools or methods for that refresher training. Just however, we will be checking in from time to time to make sure that everything is in compliance and that DSPs are being informed of the latest updates, as well as to make sure that DSPs are aware of the continuing guidance.
Okay, there's an additional question for DC Health, but we're having some technical difficulties right now. I will try to, I'll send the question to Daryl in hopes of receiving a response from her. And it's in regards to the ICF guidelines.
Nelson, are you able to speak? Are you having, can you connect? Maybe Nelson can answer this question in the meantime.
Can you guys hear me? I'm not sure. I was having difficulty earlier. Okay. So basically, for as far as updates for the phase 2 guidance for visitors, specifically for the CMS's document that they released, we're not going to comment on that at this time, but there is some updated guidance for ICF, as Daryl had shared, that is in the works and through the final stages of being approved that should be released hopefully soon, that can provide some clarification.
Okay, and Daryl responded in terms of the face shields that the direct care provider, if the direct care provider lives in the home with the person they are serving, then they are not required to wear eye protection.
So yes, correct. Because I'm sorry, and I hope you guys can hear me now. I apologize for my connection issues, but as of previous guidance, the CRF and supported living guidance also mentions this, but essentially, if you are a household member, if you are living in the home together, individuals living in the home do not have to wear that eye protection, etc. So I know that there are some, maybe some individuals who live in the home with the person they are providing care for. They are not the same as other direct care providers who provide care for individuals who they do not live with. And in that instance, if you do not live with the individual you are providing care for, we do require you to wear the appropriate PPE, which is in this case, universal eye protection and universal masking. And I hope that clarifies that. And I did get clarification from internally from DC Health. So that's our update on that particular question. Thank you.
Thank you. Deputy Kirk, if you can, in terms of the weekly trainings, in response to the COVID-19 trainings, can you clarify whether it's weekly or bi-weekly?
If you're answering, Kirk, you're on mute.
I'm sorry, my computer actually froze. I'm sorry, I did misspeak earlier. It is bi-weekly refresher trainings. My apologies. It is bi-weekly, just to clarify.
Okay. Can you please let us know how many day programs have been approved to reopen? Have the service coordinators started scheduling the CPAC meetings?
Sure. So I'm sorry, my computer is freezing a little bit, so please let me know if you can't hear. So far, 11 providers have been approved to resume day services. I'll type it into the chat box, but I'll also tell the names. So as of today, it's Excellent Community Services, Art Enables, Bridges Center, UCP, Superior Help in Hands, Global Resources and Supports, Health Tech, Capital Care, PSI, Metro Day, and Brooklyn Senior Daycare Center. I believe as of today, the deadline for submit and reopen plans is today. And I think we've received about an additional 5. So I think the grand total of providers that have applied for reopening is at 26. We are in the process of working on approving those plans, and we'll give an update next week on where we are. And it is my understanding that the the DDA service coordination team has begun their process for CPAC. I'm not sure if there's anyone on from Health and Wellness or from DDA who can verify that, but I do believe they have started CPAC meetings.
Yeah, and as each of those plans are approved, they are forwarded to service coordination so that they can then start their planning.
Okay. All right, and someone just made a comment that they paid staff whenever they train, the cost of training every week. The logistics are burdensome. And in terms of training, they do train whenever there's updates and the situation evolves. And that's not to include other mandated trainings that they do with staff. So just curious in regards to the ongoing trainings for DSPs.
You know, one of the things I would say about this, and then I'll defer to anyone else that wants to jump in, is that these are sort of online trainings then that can be completed by people and could be completed by everyone in the home, DSPs as well as the people that live there, because it is going over information that is very important, I would say, to continue repeating. You know, our most recent, or one of our more recent outbreaks at one of our homes did relate to someone who was not using PPE properly. And so, you know, in terms of education, I don't think it's at all one and done. I think it's essential to continue to repeat. And, you know, I'm noticing that today we haven't said, although in most of these weekly meetings, I always get back to the importance of maintaining social distance and what that means in terms of standing, you know, if your arms are out and the other person's arms are out, at least that far from people. Always having on face covering when you are, for people supported by us, anytime you leave your home, when you're going to be around other people, frequent hand washing, and, you know, repeating this frequently to make sure that it is information that people, you know, not only that they learned it back in April when it was provided the first time, but that they're reminded of it, and that they're reminded that it's still essential to do. And so, you know, I think there are ways to build it into the sort of natural flow of the work that people are doing, so that you are perhaps having training that includes the people that live there as a reminder to them, especially as we're talking about returning, you know, some people returning to some day services who may be leaving home. How do you stay safe in those circumstances? So some kind of training like that in an ongoing way, as an ongoing reminder, is essential.
And in response to the day programs being approved to reopen, there was a question as to whether service coordinators started scheduling the CPAC meetings. The response to that is that they are scheduling meetings for providers with approved plans.
And Crystal, I just want to add, I actually just realized there's an error. So there were not 11, there are 12 providers that have been approved. In addition to the providers I mentioned earlier, Phase 2 Academy has also been approved. Thank you.
Okay, thanks for that. Another question, more of a scenario. If person A was receiving in-home support since January 2020 and service is billed with an existing PA, now do we stop billing that service using that existing PA after March 16th and continue the billing under Appendix K?
I'm not really understanding the question. And it may be, it's like a waiver / DHCF question in terms of whether our authorizations include what's necessary so that people can use the codes that are in the Appendix K to submit claims to Medicaid, or if a new authorization needed to be issued based on the Appendix K new service codes. And there may be someone here that can answer that, or even any one of the providers, because we are now all the way, we are 6 months past this thing starting. So I expect people have been paid for some services provided over the last 6 months. I also, Crystal, saw some questions that I have not in the chat box that I have not heard. And I know it scrolls pretty quickly. Because there was one about visitation. And I'm trying to get to it.
Correct. That is I believe one of our DC partners responded to that. The Phase 2 guidance, is that what you're responding?
Yeah, the question about, because the visitation, because CMS CMS issued new guidance regarding visitation recently, and there was a question about whether that will be addressed in any upcoming changes to guidance from DC Health.
Hi, this is Daryl Hawkins from DC Health. Yes, we are aware CMS released new visitation guidance for multiple healthcare facility settings, including nursing homes as well. What I can tell you is that DC Health is having discussions about addressing this new CMS guidance and providing really some clarification on if what providers should do if DC Health guidance is more restrictive than CMS guidance, or if we need to edit our guidance for that. So we don't have an answer for that yet. We are aware of it. Our leadership is talking and also I think collaborating with HRLA as well. But we don't have yet an answer. They are in the middle of discussing that right now. Thank you.
Okay, we have a couple of more minutes. If you would like to type a question in the chat box, please.
Crystal, I will add, even though I will be sending an email out to all providers with the link for the provider training, I'm also providing it in the chat box right now. It is currently up on our website, and I'm providing a link in the chat box, as well as going to provide an email with the link to all providers. Thanks.
Okay. For people who have not chosen to return to day programs due to ongoing concerns, the team has recommended companion services for them. However, service coordination and waiver are not able to approve one-to-one services for them, and therefore this becomes difficult to provide companion services to this person, especially in natural homes. How can we go about this?
I'm not clear why it would be that they're unable to approve companion services. This has been included. Our amended Appendix K clarified, that we have the 1 to 2 companion rate, but companion services have been included as a service, and they've been included in our Appendix K since March. And so what I would ask is if you could ask that service coordinator to elevate this to their supervisor for assistance with, what is the barrier to approving a service that the team has agreed is the appropriate service for the person. So there's a response here saying that people in natural homes were told that companion would only be approved until May 15th. That honestly is sounding like a very case specific issue, which really should be elevated to that service coordinator supervisor. The 1 to 2 was for places for, and then there's a question about how could you do 1 to 2 in a natural home setting. Well, you could do it if we have a natural home setting where there are 2 people who are both supported by DDA. There are probably other ways you could do it as well, in that if you work with more than one person and they want to get together, but someone else is also asking whether IDS could request 1-to-1 due to COVID, and those also are very person-specific questions that should be answered by the team.
Residential providers are currently providing companion services, which day program was providing until this pandemic. Can day programs not return to providing these services? Residential providers are using this to prevent some of the persons to return to the day program because they are benefiting financially. How can DDS address this?
The way it's being addressed is through the IDT, the interdisciplinary team meeting, to discuss, as we've completed a community participation assessment and questionnaire, and whatever day service the person was receiving prior to COVID, to the extent that person is still interested in working with that same provider, they'd be invited to that meeting, and there'd be a discussion amongst the whole team about which are the most appropriate services for the person. The focus that we would have is on the person and the services that best meet their needs, what's important for them and to them. I think that what we have seen is that residential providers have had to step up and provide 24-hour care for people for 6 months now. And, there is concern as you try to transition from that model where people are there in the home 24 hours a day. How do you do it in a way that, ensures the person's safety and has the stability of staff for the people in the home who still need it? So there are, there are complicated questions as you begin to transition back, and that's what these team meetings are for. And the focus of the team meetings is how we meet the needs of the people that we support. And I expect that to the extent a service coordinator needed support in advocating for the person, feeling that providers were not advocating in the person's best interest, that they would get that support from their supervisor or up the supervisory chain, or to the extent necessary from their quality resource specialist if it came to that. So I see it is 1:05. Thank you, everyone, and we will talk next week.